public health crises since the AIDS epidemic. We need a new way of thinking about opioids, a new way of thinking about treating chronic pain. We need a new framework, in a word. As a psychiatrist who has spent most of my career understanding the role and impact of trauma and violence on the lives of the people we serve, I have long been aware of the psychic suffering that such exposure causes. And today, the speakers are going to help us also understand its impact on physical pain and the connections among physical pain and psychic pain and trauma, and the treatment approaches that logically follow from that new framework. Thomas Schrattenholzer, Anderson Rice, and Nora Stern are going to start us off by setting the stage by explaining mechanisms of persistent pain and non-opioid treatment modalities. Lydia Bartholow and Melissa Weimer will help us know practically what to say and how to say it and what to do when we work with people in pain and who are thinking they need opioids. And then, after lunch, Rachel Soleratoff and Anderson Rice will give you all the information you need to recognize and help those people you serve who struggle with addictions. I want to recognize the Northwest Addictions Technical Transfer Center and Oregon Health Sciences University for their partnership with HealthShare of Oregon in bringing today's conference to you. I also want to thank the planning committee, who is made up of all your speakers today, with the notable addition of Christine Bernston, who has helped bring this conference to you, and she really makes it look easy. In fact, it must be easy, because you always make it look easy. So thank you for coming today, but most of all, thank you for your commitment to improving the health and well-being of the people that you serve. Welcome.
Hi, I'm Rachel Solitaroff. I'm the Chief Medical Officer at Central City Concern. I've had the great privilege of being the chair of the planning committee for these events over the last 18 months or so. I'm just here to give you a couple housekeeping items, as they say. First thing is, this is the third of our day-long events. And we'd gotten positive feedback about the first two. So what we've done with this third one is create kind of a mashup of the previous two. So what that means is if you've been to none of them, this will be new information for you. If you've been to either or both of them before, some of this may sound familiar. So you're welcome to nap, head downstairs to the, it's a nice hotel. But if some of this sounds familiar, if you've been to previous ones, it's because we've constructed it that way. A couple little items you should know. One is to be sure to sign in. You can get CME or CEUs for this event, but you'll need to sign in at the front, at the check-in desk there in order to do that, and then complete the evaluation at the end. There's also a nice, if you didn't grab it, there's a nice handout of resources about substance use disorder services around the Tri-County area. My thanks to our health educators at Central City Concern for putting that together. We'll do question and answer at the end of each session, and a final Q&A session at the very end of the day. If you're really moved to shout out a question, nobody's going to stop you, but we also have designated times to ask questions. And then there are microphones kind of at the front of the room to do that. And then just lastly, I really just want to deeply thank HealthShare for setting aside its transformation funds to make these events possible. I remember, as I usually do, complaining loudly at a meeting one time that everybody's talking about addiction and there's no addictions education in this town. And so HealthShare, in their usual way, said, fine, do something about it and we will help you. So it's without their sort of vision and leadership and support, this wouldn't be possible. So thank you, HealthShare, for doing this. And with that, I will hand it over to our first team of speakers. Enjoy the day.
Thanks, Rachel. I'm Nora Stern with Providence. I'm going to be part of this first section, and I'm just going to kind of orient you to what we're going to be talking about. We're going to be talking about mechanisms of pain and persistent pain and non-pharmacological options for care. So Thomas Schrattenholzer will talk in the first portion about how pain works in the brain and the nervous system in the body. And then Anderson Rice will be talking about anxiety, trauma, depression, and its relationship to pain from a behavioral health perspective. And then I will be talking about how you talk about pain and the importance of changing the language that we use when we talk about pain, and then the role of rehab from my perspective as a physical therapist, and then looking at other non-pharmacal options, particularly that are laid out in the new OHA guidelines that will be coming up in July 1. I know that as we were developing the planning for this, we realized that there's a lot of urgency in understanding more about some of the specifics of those interventions, what they can be helpful for and not. So we'll talk about that, and then we'll all come up and look at a case and ask you all to think about the non-pharmacological options that we looked at and help, and we'll develop a treatment plan together. And then that will segue into the question and answer section. So with no further ado, Thomas Schrattenholzer.
Good morning. The topic of my talk is really how does pain work, and it's interesting that over the last 20 years, being a young doc who's kind of just growing up with new understandings of how this experience actually develops in our comes to our conscious awareness. As an anesthesiologist, it was great because we were able to almost control every aspect of our patient during that finite period. And as I moved out into chronic pain, it is a whole new world. And I'm hoping to just share some of the things that I picked up along the way. I don't have any affiliations with anyone except for Epic, and I feel like that guy over there. The objectives for today is really just talking about how we understand pain in terms of an adaptive model, and how we need to, in order to be more effective with folks who have persistent pain, expand our understanding of how it works, because it'll change the way we choose treatment options. So the way we understand pain in the world today is actually adaptive, right? So it protects me as I am trying to get around in my day-to-day world. This is a picture of somebody putting his hand near a hot stove. As you put your hand closer to that hot stove, you'll start to stimulate some temperature receptors that will send message to your brain that, hey, there might be some tissue injury coming up. And that as you continue to put your hand on the stove, you'll create actual tissue damage. And the intensity of pain tends to correlate very well with tissue damage. So that's the adaptive model. It's the model that is actually pretty new. Back well before 1600s, we used to think that pain was really coming from the gods. And there's some other theories and so forth, but basically this is Job being tormented by the gods. It wasn't until Rene Descartes in 1664 said, pain's coming from within our own bodies, not from outside ourselves. It's like a string that's attached to a bell in our head, so that when the string gets pulled or activated, a bell goes off in our head. And that's pretty much how we understand pain today. We're a little more sophisticated about it, and there's a lot of great scientific data about it. And those of us that are allopaths have been kind of entrenched in this. But basically, you have somebody who experiences pain. What we imagine is that there is some kind of tissue damage. I love the red on this. showing where the problems may be. This is a picture from Netter, but it could be the facet joint, the disc, it could be pressure on the nerve. And so we're actually going to do something about it, right? We understand that what happens here is a process called transduction. Transduction is when specific receptors called nociceptors are activated. They tend to be pressure, temperature, and chemically activated. They will depolarize the nerve and send a message to your brain. And you can stop that by putting local anesthetic or steroid around it. And if you can't stop the transduction, you might be able to stop the transmission and modulation. So the nociceptive fibers are A delta and C fibers that connect to the lamina and the dorsal horn of the spinal cord that then sends it up the spinal thalamic tract. So this is a picture of an X-ray, just a lateral X-ray of a really nice gentleman that I work with who had this problem right here, right? And in order to fix it, he got fused, right? So we're going to decompress, take the pressure off so that these receptors aren't being activated. And when that didn't work, he has something called failed back surgery syndrome. We're going to put it right back onto the patient. He failed it. So when that didn't work, he got something called a spinal cord stimulator. And I don't know if you can see that, but these little leads are all the way up to the. So has anybody seen a TENS unit? Right? So this is basically a TENS unit stuck on an epidural catheter that goes right over the dorsal column of the spinal cord. And you can turn it on just like a TENS unit, right? And you can get stimulation. It actually works pretty well. It just doesn't work well for long. So when it doesn't work super well, then we're going to do something else. We'll put in a pump, right? So this is an intrathecal opioid pump. It's a reservoir. So this is the reservoir right here that sits in the subcutaneous tissue. It's a little bit like a pacemaker that sits under the skin, and it pumps solution into the intrathecal space. The opioid binds to the neurons in the dorsal horn here and suppresses the transmission of signals to the brain. And when that doesn't work, right, then we suppress the brain, right? So that's when we go for it. And we go for oxycodone, right, or some kind of opioid. And this guy has all of it. And guess what his pain is? Still severe, right? So what do we do? When we apply the adaptive model to a persistent pain problem, which we have done over the last 20 years, and Richard Dio, who's a researcher at OHSU, did this really nice study of Medicare data, showed that between 2000 and the mid-90s to the mid-2000s, we had an increase of 420% for prescription analgesics. The injection rates went up about 600+%, and so did lumbar fusion rates. And we think, gosh, what do we get for all of this? Well, it turns out not just nothing, but actually a worsening of problems. So according to this U.S. Medical Expenditure Panel survey, during this time where we had this massive expansion of applying opioids, injections, and fusions, we actually had an increase in dysfunction and disability, as well as an increase in opioid-related deaths, which is kind of what brings us together today, I mean, partially anyway. So we should think about times when we don't have an adaptive model. So this is just a diagram of pain intensity versus tissue disruption. And this is where you have massive tissue disruption, but you don't have any pain. So we can come up with a couple of cases. So maybe during trauma, right? So this is a surfer. He gets bitten by a great white shark, and he didn't actually feel any pain during that time. and there's good reasons for it. All of these actually have similar scenarios. This is a guy who was making a shot, came down on his leg, and ended up getting an open fib fracture. He didn't actually know that he was injured. I mean, he knew something was wrong, but what cued him in was his coach just gaping like, oh my word. Beecher, though, from published in JAMA in 1956, he was taking a look at World War II veterans, and what he found was, compared to civilians with similar injuries, the soldiers needed 5 times less morphine and had fewer complaints. We can think about it the other way, where we have almost no tissue injury, right, but massive pain intensity. What's going on there? The classic is actually phantom limb pain. This is a person who has had an amputation. It's all healed, right? There isn't any nociceptors being stimulated, yet even when the portions needed to transmit pain are gone, pain can be focal and very intense. In our world, we see a lot more of this, which is fibromyalgia, which if you take a look at the actual tissue, there isn't any inflammation going on, yet when you press on those tender points, they are very painful. So in most persistent pain cases, pain condition, or the tissue pain intensity correlates very poorly with tissue damage. This is a study by Kramer, who took a look at osteoarthritis of the knee. So this is kind of a quintessential peripheral pain problem. There's a grading scale. This is grade 3-4. This is what we call kind of bone-on-bone pain. And what they found was that x-rays poorly correlated with symptoms, and that up to 50% of those that had evidence of osteoarthritis of the knee actually didn't have pain. And 10% of those who had no radiographic evidence of osteoarthritis had severe pain. And psychological conditions didn't actually fully account for the differences. Medications weren't all that effective. Non-steroidal anti-inflammatories, opioids, and Tylenol didn't have much of an effect. And even when you replace the joint itself, up to 20% of hips and 25 to 30% of knees actually don't get the pain improvement that we're looking at. So, what is the mechanism that really explains all of this? There's two influential researchers that have helped open and shed some light on this. The first one is actually Louis Gifford, who in 1998 came up with the mature organism model. But basically what he said was information comes in to our brain. The brain scrutinizes it. It kind of compares it with past experiences, knowledge, beliefs, cultures, past successes, other people's successes, and that ends up changing our behavior and actually our physiology, which then in turn changes our environment and our tissues, which then again sends information back to our central nervous system, which then again scrutinizes what's going on. Another researcher is Ronald Melzack. So we know of Ronald Melzack because of the gate control theory and the he's one of the early pioneers at McGill University doing pain research. And basically he came up with the neuromatrix theory of pain, which is kind of more of the scrutinizing mechanism, taking a look a little more at how the brain actually does the scrutinizing. But he basically says, listen, there's input coming from the sensory, cognitive, and emotional areas of our brain, and then it makes an output. And one of the outputs is actually pain, but also action and then the stress response. And Melzack said, listen, our entire experience is made up of neurons and neural connections that are organized into modules, and these modules communicate with one another. And he called the whole process the body self neural matrix. And what he says is that the sensory input converges and then again diverges with cognitive portions of our brain, like memory and so forth, and the affective portions of our brain, like our emotions, and that these are continually coming together and then spreading apart again and influencing one another. So, and creating the outputs, which is the location, intensity, the meaning, the actions that we take. Like if I twist my ankle, what am I going to do? I'm going to grimace. I'm going to hold my ankle, sit down, yell out, swear, something like that. Right? I also have an increase in my norepinephrine, adrenaline, cortisol, and activate the immune system. And this is going on all the time. And this is an example of locations in the brain that are being looked at using new functional MRI scans. But basically, pain is produced by these coordinated patterns of nerve impulse firings called neurosignatures or neurotags. And that these subsignatures that are impressed on other subsignatures to make larger neurosignatures that are continually being presented to our stream of awareness, and then these are translated into for moving us towards a goal. So where are these areas, and how do we look at them? So we look at them using a lot of neuroimaging techniques, but the most recent one is functional MRI scans. This is an example of a functional MRI scan that is looking at the somatosensory cortex, the insula, the ACC, and so forth. The somatosensory cortex tells us the location, intensity, where is this, and the insular cortex really integrates the sensory, emotional, kind of cognitive states. It's where empathy for others shows up. The anterior cingulate cortex registers the unpleasant feelings when things go wrong physically or emotionally. And then the prefrontal cortex, where we do our planning, our thinking. And the medial prefrontal gyrus, which has the potential negative implications of the experience. And then the right orbital frontal cortex. There's actually quite a few others. So I didn't talk about the amygdala, the hippocampus, and all the rest. What the point of this slide is that this is one of the hottest areas of research right now. So this is an article out of the New England Journal of Medicine in 2013. Wager, a psychologist out of Colorado, published a paper taking a look at fMRI scanning and looking at these neural signatures. And he was able to tell the difference between thermal pain, pain anticipation, pain recall, and rejection, right? The pain of social rejection. And he was actually able to predict, just based on images alone, what the pain intensity would be for thermal pain. So it substantiates a lot of what Gifford and Melzack were saying. We know that persistent pain is a different state of the brain. What happens is that the somatosensory cortex and the ACC, they get bigger and more widespread, and they become active on both sides of our hemispheres, which helps account for, in persistent pain states, the diffuse nature of the pain experience. The insular cortex does something similar. We think it's associated with a condition called allodynia or hyperalgesia. This is where just blowing air over an extremity causes severe pain. So that's allodynia, or something that would be mildly painful is excruciatingly painful in hyperalgesia. We know that in persistent pain states, compared to healthy, there's more activity going on. That their neurotransmitter release, gene expression, receptor sensitivity and availability, cure responsiveness are all magnified in a persistent pain state. And the question is why would that be? And that's because as neurons remain active, the neurons that fire together wire together, and they reinforce one another over time. There are other components to why we hurt the way we do. One is just our volume control based on our genetics. There are also neurohormonal factors that are associated with where our volume control is going to be set. And then there are social determinants as well. So folks who have better social health also have better physical health. And this actually may account for a lot of the stress response that we see with a lot of our patients who have persistent pain. So in summary, to sum it all up, persistent pain does not correlate very well with tissue damage. The theories that seem to help explain this the best at this moment is the mature organism model and the neuromatrix theory, where inputs from sensory, cognitive, and emotional areas of our brain are cyclically processed and produce outputs, that one of which is pain perception. And that these new outputs create new inputs. Genetic and social factors play a role, and that pain can be understood, and this is a quote by Leila Mosley, who's a pain researcher and a physical therapist in Australia, said pain is an unpleasant conscious experience that emerges when the sum of all available information suggests that a body part needs to be protected. This is also one of his creations, I think with Butler as well. And I like this slide because it really helps look at how the different contributors to the pain experience change over time. So when we have an acute injury, I twist my ankle, peripheral processes play a major role in that. But as that ankle develops into, say, CRPS or something that has more of a persistent pain state, central processes play a much larger role in that pain experience. And it's important to understand that so that we change our treatment modalities to more collaborative care models, where we do more education or information giving, education, and then reassurance. The treatments at this time for persistent pain seems to be somewhere around 30%, no matter what you are looking at, and particularly medications, but even 30% can be significant for somebody who's experiencing pain persistently. Differences between peripheral and central pain states. Peripheral, we really mean mechanical, kind of inflammatory. The great examples are surgery and trauma and osteoarthritis, rheumatoid arthritis that tend to happen in older patients, and physical therapy and drugs like nonsteroidal anti-inflammatories and opioids all seem to be useful. In central pain states, it has to do with symptom amplification and often a processing problem, so fibromyalgia, interstitial cystitis, low back pain, headaches, irritable bowel syndrome are all these more of a central pain state amplification problem. It happens in younger patients typically. They tend to be the most common of the persistent pain states. And non-drugs such as sleep and activity are useful, and antidepressants and anti-seizure medications tend to be the medicines that work the best. And we were going to be talking about treatments. When I think about treatments, I think about them in two forms. One, either passive or active. When we are using the adaptive model of pain, we're actually talking about a lot of passive treatments. So it's got this fix-it approach. We're going to use medications, sometimes acupuncture. Not that that's bad. None of it is bad. It all can be very effective. It's just choosing it for the right patient at the right time. Active treatments tend to be only things that the person who's experiencing pain themselves can do. So it would be participating in a home exercise program or working with moving your mind, say like cognitive behavioral therapy. The passive treatments tend to be fast, effort independent, and unfortunately covered, while the active treatments tend to be slower, effort dependent, and often not covered, although that is changing, and Nora is going to be talking more about it. For persistent pain states, the passive treatments tend to be temporary with kind of an external locus of control, and active treatments tend to be more longer lasting and have this internal locus of control for self-management. While we're not going to be talking about meds very much, I felt it my duty as an anesthesiologist to talk a little bit about meds. I saw this slide a month ago in Austin, and I loved it because it's exactly how we often are approaching persistent pain stage, just sitting here waiting for my meds to kick in. So what meds are we talking about, and where do they work? Most of the medications that we'll be talking about actually work in the spinal cord and the brain. They use specific neurotransmitters in those pathways, including glutamate, substance P, and other cytokines. The descending pathways use serotonin, norepinephrine, GABA, and interestingly enough, glutamate again. The opioids work typically via mu and kappa receptors in both the dorsal horn of the spinal cord and the brain. The non-steroidal anti-inflammatories mostly work in the periphery as they inhibit cyclooxygenase enzymes, reducing inflammatory cytokines and prostaglandins. So antidepressants increase serotonin and norepinephrine both in the spinal cord and in the brain. Interestingly, for antidepressants, for pain alone, you tend to need lower doses than you do for depression. Anti-seizure medications work a variety of ways, either blocking calcium channels or sodium channels, but they all do the same thing, which is reduce glutamate, which is activating neurotransmitter. Muscle relaxants all tend to be central nervous system depressants, with the exception of tizanidine and baclofen that work via somewhat different mechanisms. Cannabinoids inhibit mast cells, so they may have an anti-inflammatory kind of effect and can stimulate opioid receptors in the brain. Capsaicin depletes substance P, which is kind of stuns the pain fiber, for lack of a better word, or the nociceptive fiber. NMDA receptors such as nimantadine, ketamine, methadone, dextromethorphan bind to glutamate calcium channels. These can be very potent forms of inhibiting the ascending pathways. This is a summary slide of what I just reviewed, and I will just skip over that. Getting to more of the active strategies, physical activity, and Nora will be talking a lot more about that, improves just our physical conditioning and being able to get around in the world. And with joint mobilization, improved tissue health, the relaxation. So after exercise, we're able to relax better. It reduces the number of flare-ups and it helps improve our mood. Exercise and prevention of persistent pain has been shown to be effective in reducing the movement of acute pain to persistent pain. And we think it's because it activates descending opioid receptors in the descending pathways of the spinal cord, as well as kind of increases anti-inflammatory cytokines. Affect regulation, so I call it physical therapy for the mind, are cognitive treatments, the very first of which really is information. So when we think about helping reduce persistent pain, changing the way we think can lead us to new and maybe even better options. So just information alone can be helpful, and Butler and Mosley showed that. Cognitive behavioral therapy, where unhelpful thoughts and behaviors contribute negatively to negative feelings, tend to increase pain sensitivity. So addressing those things, including working on improving coping skills and increase confidence and self-efficacy, which is basically kind of returning to an internal locus of control. Acceptance and commitment therapy, we'll hear more of that from Anderson Rice. The basic tenet of it is that pain cannot be avoided. The Eckhart Tolle teaching that which we resist persists, and being willing to observe our thoughts and feelings without trying to change them, and then behaving in ways that are consistent with our goals and values. This has actually been studied by a guy named McCracken in 2004, and he developed a questionnaire, and he found that there were two important aspects to acceptance. One was just the willingness to experience pain, and then the other was being willing to engage in valued life activities, even though you're hurting. And what he found was that those that had a higher level of acceptance of their pain found that they experienced a lower pain intensity, less depression associated with their pain, better social and physical activity, and less kind of pain avoidance, better work status. And this was kind of independent of the original pain intensity. Sleep, as I was showing you on the fMRI scans, the brain is a very active during a persistent pain experience, and sleep is important in rejuvenation of our neural networks. So folks who have persistent pain states, sleep tends to even be more important. The integrated approach seems to be the best in terms of being able to reduce pain over time. So instead of just having monotherapy, an integrated approach where we take a look at what's going on medically. Is there something that should be addressed and needs to be addressed from a kind of a fix-it perspective? Also movement of the body and then movement of the mind as well. So in summary, persistent pain is a complex neurologic state that seems to be best explained by the mature organism model and the neuromatrix theory of pain. And understanding it this way tends to change the way we think about what will be useful in chronic for those who experience persistent pain, and that movement of both the body and mind are essential, and the passive treatments tend to have just limited effects. And then, if possible, an integrated strategy gives us the best treatment outcomes. So with no further ado, I think it's Anderson Rice.